Um, oh, hey, everyone. I'm Carlene. Thanks for all being here. I'm really excited to walk you through our problem solvers case today and just really highlighting the main teaching points. So let's just get right into it. The chief complaint here would be bilateral lower extremity weak swelling. So we have a 43-year-old male presents with progressive bilateral lower extremity swelling for a month, which is now involving hands and feet, face. Some associated symptoms would be some unquantified weight gain, daily fatigue, headache, intermittent nausea and vomiting, abdominal distension, as well as dyspnea on exertion. And review of systems, he really denied of any fevers, chills, weight loss, night sweats, dysuria, cough, or any arthralgias, as well as some social history. He just recently traveled to India in the last month and a half, but he denies of any preceding illness. Like I mentioned, any cough or arthralgias as well from prior to that. His past medical history, he is a healthy, active man. He's also a vegetarian, and he eats a lot of protein, vegan. He's really in a vegan vegetarian diet. He does consume lion's mane for the last 2 weeks prior to his admission. He consumes or takes Chinese herbal medicine as well, and ibuprofen on a daily basis. He also has marijuana use. He denies of any IV drug use, as well as has a history of smoking, but really just maybe 3 cigarettes per day. Family history, his mother had passed from presumed autoimmune kidney disease. His uncle died from ESKD due to diabetes. Allergies, no known allergies, and his vaccinations up to date.
Well, we can stop there. So, Julia, you want to tackle Colleen? Fantastic first aliquot there. So, Julia, what do you think of this at this point?
Thanks for letting me take the first aliquot. I think, Colleen, I wanted to emphasize before we started that I'm so happy to have you, and it's the first time presenting, and you present like a pro. So really, really grateful for your time. And you said, well, you just finished med school and presenting even for steps and taking the time. Really appreciate it. And I don't want to break our ritual to just thank and introduce the people that make the session happen, because today is really special because our community just has many people that are always jumping in. It doesn't matter what comes and happens to other people who volunteered. So today, a special thanks to VJ and Simi and Eugene as well, who is supporting the team last minute with teaching points and scribing. It's phenomenal that there's always somebody helping out. So thank you first. But getting back to the case, there was such a great start. So just to summarize, I think the chief complaint is clear. We have a 53-year-old man with bilateral lower extremity swelling. And I mean, lower leg edema is something that has been discussed many, many times on VMR, but I think it's always very important to start with fundamentals and also the baseline. So if we have like bilateral lower extremity swelling, we always think about the kidney, the heart, or the liver. I mean, base rate, well, I always first consider if there's any like heart disease in the background, and it's could be either like an underlying heart failure or an exacerbation of heart failure in the background. In this case, the our patient is quite young. He's 43-year-old. Could be the heart could still be on the go, but I would also likely consider any liver or kidney disease in the background. Um, I mean, what I did think about is the when we think about edema, we often have like a disconnect between or a lower oncotic pressure in relation to the like gravity pressure that is pressing water into like outside of the vascular system. So thinking about that, we can always think about like low proteins in the blood, either thinking about do we not have enough intake of protein, which in our case could be considered, since I think Colleen mentioned that there's a special diet going on. You don't have to have deficiency in the vegan vegetarian diet, but always consider that there could be some like low intake issue here, so low protein diet maybe, and also other deficiency, vitamin deficiency as well. The second thing, thinking about proteins, you could also lose proteins in the kidney, for example. So thinking about nephrotic syndrome, where you have like a hypoalbuminemia and also edema. And then I would just be curious if I have other compensating signs and symptoms in our lab. So thinking about hypertri or hyperlipidemia, just to compensate for the protein loss. I would be curious if there's a propensity for infection, because you also use immunoglobulins, so a lot to think about there. Yeah, that would be like the kidney part. At the moment, we don't have, or we would have also the liver bucket still on the hook. I mean, it's the first aliquot, since there is some Chinese herbal medicine in the history. And first of all, kudos to you, Colleen, that you took this history. I think many of us forget that supplements is an essential part of taking a medication history. So that is something we should at least have in our in our back mind. And also, of course, travel history can also always be like make you prone for any infections, but it's very unspecific at this moment. So I think heart, liver, kidney on the hook because of its age, his age. I would even consider like heart being a little less likely, but you never know. Please, Ravi, any thoughts you want to share, or should we get more
Sure,
information?
sure. I think I really don't have anything. I think you just took us wonderfully through the whole landscape of what could be causing this. And while you were talking, I was just reflecting on how powerful this platform is to bring you in and be able to shine a spotlight on your abilities, and whatever you have learned through this platform, you were able to reflect in a session like this. So it's remarkable at this stage that you were able to comb through all the different systems that are usually the culprit for something like this. I just want to add the gut could be, diarrhea could be potentially a cause. You could have protein losing enteropathy. But at this point, I don't think there's a powerful signal for one of the organs. There is something end stage kidney disease in the uncle. I don't know if that has relevance, but I think you pretty much have named the possible culprits here, and then we will further explore with acquiring additional data. So we'll turn it back to Carleen. Absolutely wonderful case, Carleen, for us to dwell on.
Thank you, Ravi. So just going to the next aliquot here, we have our physical exam, including the vitals. So he was hypertensive. His BP was 176 over 111. His heart rate was 74. He's respirating around 18. He's setting 95 on room air, but he remains afebrile. General appearance, he was non-toxic, no jaundice. He was having some periorbital edema, but very mild, although he doesn't have any sclera. He was just anorectic. Cardiovascular respiratory was very unremarkable, clear lungs and regular rate rhythm. His abdomen was soft, non-distended, non-tender. Extremities was notable for symmetrical 3+ pitting edema down all over his legs and hand swelling, and some, which is very mild, but no rash. His neuro exam was benign, alert, and oriented ×3 as well. Should I jump right into the labs?
I think we could stop here. I'll kind of take first stab. I'll take the vital signs here. So what really jumps out here, Julie, you're probably like thinking, oh, the blood pressure. Several people in the chat have already discussed the blood pressure. So it was very interesting. Like, how much significance can you extract from a blood pressure this high? So the question is this blood pressure inherent in this patient? Blood pressure can be very disturbing to the body. It can cause several life-threatening conditions, especially when you're in the domain of malignant hypertension or hypertensive emergency. And the other thing is there organ that can actually be blamed for the edema and can scream out its signal? It's sort of like a bat signal. Hey, I'm having trouble regulating the blood pressure, so can you come help me? So the edema is one signal that the patient came to the emergency room and the blood pressure is way out of control here. As you well know, when you lose kidney function, you lose the inherent ability to release volume. When the body has sensors that are able to sense that the blood pressure is way out of control, you will have several neurohormones released, which will allow the kidney to diurese. So you have intrinsic diuretic factors that we aim to capture also in congestive heart failure with numerous medications that are able to simulate or prevent the breakdown of AMP. You know, it was interesting. Years ago, we actually used to give AMP or BMP intravenously on telemetry floors, and then data came out that it actually increased mortality. So up until the sacubitril and valsartan, we didn't really have anything. I forgot the name of the medication, but it used to be a drip. But so with this, yeah, it's highly suspicious that this could be an indication, a downstream reflection of the kidney being involved here. Looking at the rest of the vital signs are fine. There's no there's no fever that could indicate inflammation, infection. So that's pretty much the significance I could extract from this. Anything from the physical exam that has your attention, Julia?
No, that was beautiful, Rory. The one thing I would love to add is just that my alarm signs are a bit alert at the moment, just because we have the combination of hypertension and some suggestion for kidney disease due to the hypoalbuminemia. So we have to consider RPGN and just as the most morbid differential diagnosis at this moment. So I would really love to check the UA as fast as possible, looking for any dysmorphic cells and also like blood in the urine, of course, measuring the urine albumin to creatinine ratio to quantify proteinuria. But that was just something that I thought of that we have to consider.
Yeah, Julia, what do you think? So this edema has gone from the legs up to the face, and now the face. How much kind of significance do you put on this periorbital edema, or what kind of conditions say it isn't? Oh, obviously, we mentioned the kidney, right? When you read textbooks, it does associate it with nephrotic syndrome. But what if it isn't a nephrotic syndrome? What other conditions can you think about that could give you this periorbital edema?
Oh, I love this question because we always think about nephrotic syndrome and then kind of stop. And to be honest, I really have to think hard at what else. I think a common, I don't think, but that is just my gut feeling that is very specific for the kidney. It's just something we learn about. I think also like any other disease can lead like even like heart or liver disease can also lead to a periorbital edema. But the other bucket I would open up here is just any kind of histamine release or allergic symptoms. Of course, you can have like eye infection that lead to edema. Then I would probably be led by other symptoms that the patient mentioned at this point. And I think in the context of hypothyroidism, which we haven't discussed in this case yet, but there are no like symptoms that would kind of prompt me to think about it, but still that is something I think patient can present with periorbital edema as well. Besides, please teach me, well, I was also thinking about if you have a venous obstruction of like a lower part, so thinking about superior vena cava syndrome, that could maybe be something where you just have an increased pressure leading to edema. Besides, please, yeah. I would love to learn how specific the edema, like if you have more like anasaka and periorbital edema, if there's any like actual clue that you can exclude a diagnosis or make it more likely, or if it's more something we yeah.
Absolutely. Yeah, absolutely wonderful. Yeah, you were able to sort of mention a couple of disorders that have a predilection for like periorbital edema there. And there's one in actually, there's one parasitic infection, trichinosis, that is also associated with this, which is interesting. But the hypothyroidism I've seen, which I like, I mean, I've mentioned a couple of times previously, probably when faced with this, and also SVC syndrome can actually manifest with this too, but you do also get facial edema with that as well. But yeah, you know what? What's interesting? I've never really maybe looked up why nephrotic syndrome has this association. So there is a strong association. I'm not sure about statistics, but why around the eye? So maybe something we could look up later. Yeah, let's move on to labs, and maybe we can do breakout rooms after the labs. Let people then also participate in the fun. All right, back to you, Carlene.
Great. So back to the labs now. The CBC shows that the WBCs was around 9.5 within normal limits. Hemoglobin was on the lower end at 10, consistent with some anemia. MCV is 90. As well as platelets around 378, which was normal. BMP reveals hyponatremia, sodium of 126, hyperkalemia at 5.7, chloride 105, typically normal, bicarb elevated at 38, with a BUN of 15, which is normal, elevated. Creatinine is 1.9, and glucose was 112. Liver panel, AST, ALT was 5 and 0.2 respectively. Alk Phos was 19. Allo, total bilirubin 2.2 elevated. Albumin was low at 2.2. Total protein was normal at 6.3. Additional labs included calcium, which was on the lower end, but still normal around 8. TSH at 4.84, which is a little borderline elevated. And then A1C, which was 5.2. Hepatitis panel, HIV, and syphilis tests were all negative as well. And then the lipid panel, total cholesterol was 386, which is very high. Triglycerides was also high at 267. HDL was 39, and LDL 294, which was very high. So UA shows that the protein was more than 300 mgdl, as well as RBCs more than 50, WBCs around 6 to 10, but no casts were detected. Urine protein creatinine ratio was 19.2, and then BNP was elevated at 306 as well. The imaging shows that the TT.
We could probably stop there because that's actually wonderful data. And I don't want to miss the significance of a lot of what you mentioned. But let's go to breakout rooms since it's 10:24. And then I encourage you to sort of think about what comes to mind with the UA and the chemistry and the CBC. And then maybe come back and share your thoughts. So I'll stop the recording. Okay, welcome back, everybody. Anybody want to unmute and share any thoughts you have so far with this case?
We interrupted Elena. I think she should keep going what she was about to say because it was
Oh,
smart,
okay.
if she likes to.
Hey,
Yeah,
Elena, how are
sorry.
you?
I mean, you all had fantastic thoughts as well, and I think we can like I'm just going to talk about the nephrotic syndrome part here because I think the hyponatremia and hyperkalemia is very interesting too. But I think, generally speaking, I think we have diagnosed nephrotic syndrome. So the patient, we need three components. The patient has edema, patient has hypoalbuminemia, and it seems like, if I'm not mistaken, patient has nephrotic range proteinuria. Um, so the things that can cause nephrotic syndrome are usually, we think of primary syndrome, which are way more likely than secondary things. And in adults, the most common cause is membranous nephropathy, which is a little bit unlikely here because the patient has hypertension. I think it doesn't exclude it, but it's not a typical feature. And I think there's also not a genetic component here. In children, we usually think of minimal change, which probably is also not the case here. And the nephrotic syndrome that I'm really thinking about here is FSGS, because it does have a genetic component. And usually, in contrast to other nephrotic syndromes, it does feature hematuria and it does feature hypertension, especially if it's primary FSGS. So something I would really be interesting about is also the ethnicity of the patient, because it is that FSGS is more likely in sub-Saharan Africa, and that is I think it's some like genetic variant that makes the patient more likely to getting trypanosomiasis. So I think that's kind of my thoughts, and I'm really curious what do you think of like the disconnect of the patient having metabolic alkalosis in the context of a raised creatinine, hyperkalemia that is not associated with acidosis, which I think is a really interesting point here. So curious to know what you guys think.
Yeah, absolutely. Julia, what do you think at this point? Elena, thanks. Lots of great points that you'd shared with us.
I think that was very well, I was in a group with Elena. That was pretty much what we discussed. I think what was striking, besides the nephrotic syndrome in the background, which jumps to our eyes after analyzing the labs. I was really focusing on the last point Elena made, thinking about, or the 2 points, the etiology of the nephrotic syndrome. And in this patient paired with hypertension, FSGS being the most likely cause here. But what I also focused on was really the hyperkalemia in this context, thinking about it being caused by the decrease in renal function and metabolic acidosis, but also the elevation in bicarb in the combination with an elevation in the bilirubin. So also the liver is on the hook here. So connecting these in one diagnosis was one struggle I had, or thinking about differentials if we have different things going on. So maybe like a liver infection where we have most. The panel was negative, but we haven't tested for all the like liver infection. Maybe diving a little bit in the recent travel history, or the meds that could leak to the bilirubin, and it's just another problem. Um, or if the alkalosis might just be like a volume problem and a contraction alkalosis, and still the hyperkalemia is just in the context of kidney disease. So that is just something I had in mind, and I'm very, very interested in how the case evolves now. Um, Anyone else wanna raise or highlight a comment they discussed in the breakout rooms? Because I think always there's so many groups and so many smart people having ideas. So if anybody else has a thought and they want to share, please um, go ahead if you like. If not, Ravi, I would love to learn from you.
Yeah, we can wait for 30 seconds, see if anybody wants to share.
Yeah, I actually had an opportunity to discuss the case with Carlene, and then we were discussing about whether if it was like, the cardiac as well as the renal were the main organs which were involved, and the patient is also having hypertension with wide pulse pressure, apart from the urine picture was showing both high protein as well as RBCs levels, and then there's a family history of autoimmune kidney disease. So we were wondering if the kidney was the problem which was causing hypertension and then causing issues with the heart, causing the pedal edema. And the other question which we were discussing is, it like how much do you attribute it to autoimmunity, and then how much are we attributing it to the Chinese herbal medication the patient was on? Yeah, the bicarb being 38 didn't really make sense as of yet. Yeah, but these were the different things which we were considering and discussing about.
Yeah, great thoughts, Kuchal. What's interesting with this case is in real life, you do have many detractors. You have in the past history these medications, it could be a diet. You have to be really careful, because I faced this conundrum before where we put a lot of weight, or we try to force an explanation because of what the patient has in their history, but you still have to do your due diligence and sort of filter through the data to determine all possible variants of the condition that may be contributing to this presentation. So yes, we do put weight on all of these things, but you got to be very careful. I've been blindsided in real life. There is a case, I will present this case. I do not want to disclose the details at this point, but it was a similar circumstance where the patient was telling us about these past features in their history, and it could definitely deviate you from the path in trying to determine what could be causing the patient's presentation here. But yeah, we're definitely, everybody's on board. We're in the domain of nephrotic syndrome, all the lab features Elena had went over, Kuchal also, and Julia have mentioned that. Yeah, definitely we are dealing with nephrotic syndrome here. How do we gain traction in trying to get to which variant? And we've mentioned all possible features. HIV is negative, so HIVAN is kind of out of the picture. FSGS definitely is one of the potential causes here, membranous and so on. We can run the whole gamut of possible causes. But here, at least, we have to go through imaging. Maybe a biopsy definitely would help. And then getting some clinical markers will also be very helpful in this as well. But any other thoughts, Julia, before we move on to the next set of laboratory data?
I just wanted to thank you to remind us, and I think I cannot highlight enough how important the point is you just mentioned, because I mean, we have all the differentials in our head jumping from one to the other and try to like make sense of the data we have. But I think to get distracted by things that kind of make sense in our head is something we all fall and make mistakes. And I think just to be humble and not exclude or include things we are not sure if is something we cannot remind ourselves enough. So thank you, Ravi.
Thanks, Julia. Yeah, what's interesting here, Vinny mentioned in the chat the sodium, and what's really interesting, we can really go academic in trying to determine what the sodium, why the sodium low, go through the parameters. But here, it really doesn't really help you to get to the diagnosis here. It's a bystander or downstream effect of what's going on. So solving the kidney problem will help you with the hyponatremia. So at this point, I probably wouldn't go through all the urine sodium, urine osm, so on. Maybe even doing a FENA at this point is probably not going to be helpful. But let's swing it back to Carlene for the next bit of data.
Thank you, Ravi. So as far as the imaging, TTE was done, but it was showing normal left ventricular ejection fraction. Renal ultrasound showed no abnormalities, negative for any hydronephrosis. A renal Doppler was also done, no evidence of a thrombosis as well. They did dive into the advanced workup for possible nephrotic syndrome. So they had done anti-nuclear antibody testing, which was negative, as well as anti-neutrophil cytoplasmic antibodies, ANCA, that was negative. Anti-streptolysin ASO was negative. Anti-phospholipase A2 receptor antibody was negative, as well as anti-GBM was negative as well. Complement was done. There did show decreased C3 around 49 and a normal C4 around 25. As you mentioned, a kidney biopsy would be helpful, which we did, which was the gold standard for this mixed, this nephrotic, maybe nephritic picture. So that should.
Should we stop there a second? Julia, what do you think? The C3, so both complements are not down. One complement is down. And all the usual suspects for nephrotic syndrome, anti-PLA2R and ANCAs, ANA, because sort of, if you think about it, a lot of the nephrotic syndrome run on this spectrum. It's not absolutely one-sided. So a lot of conditions. So if you look at the complement associated nephritic syndromes, can actually run the spectrum towards nephrotic syndrome. So lupus, infectious GN, ASO is negative, MPGN can actually border on nephrotic syndrome as well. And the other ones, membranous, IgA, can. Usually the complement is not associated with that. But at this juncture, any thoughts? We kind of have excluded a good number of them. Anything come to mind?
I should now know where the unmute button is, but I don't. Yeah, I think I'm not too much surprised by this lab, to be honest, because we were not thinking about membranous in the first case with PLA2R. I think that is just something. I'm not sure how you manage it in the clinic, because I mean, it's on the one side, it's pretty nice that you can avoid biopsy and just diagnose it with a positive antigen. But on the other hand, I think the sensitivity is around 80-85%. So the negative predictive values maybe is still not enough to totally exclude it, but I'm not sure about that. But what you probably want to discuss here is the low C3 levels. And I think, like, if we think about other causes of membranous, I would of nephrotic syndrome, also like autoimmune disorders like lupus, I think you generally would have like low C3 and 4. If you just have low C3, I feel the one thing you can have, I think a C3 glomerulopathy, but besides, sometimes I think in infections like post-infectious, you can have only in decreased level, serum level of C3. But to me, I'm not confident enough to lead me in one or the other direction just based off the complement levels.
Yeah, same here. I was just wanting to see your thoughts. If both were down, it definitely would help. I don't think it really helps us to it's not sort of the catalyst or pivot point to direct us towards one of these diagnoses, which is typically we talk about the MPGN, the infectious glomerulonephritis, and lupus as well. So here, I think Davido mentioned a good point. We don't have the SPEP, UPEP, so all the usual testing for plasma cell dyscrasias, although it kind of doesn't fit the picture, but that's also one of the set of labs that we always do recommend in nephrotic syndrome. And actually, I'd asked Abby, who she said she wanted to unmute and share some thoughts. I was in a breakout room. Are you able to unmute now? Because you had a couple of really good thoughts, and you particularly mentioned a particular genetic disease, if you're able to share with us.
Oh, sure. This was back with looking at APOL1 associated FSGS. There's just been a lot of new information about that. So previously it was known that there are a lot of high risk variants for APOL1, but they've also recently discovered that if you have a modifying variant, that can actually reduce the risk of FSGS. I'm not actually thinking as much that in this case. Just with the background and all the other information that we've gotten, I think more recently it seems like C3 glomerulonephropathy, or there's also dense deposit disease. That could be another. I mean, I'm still, I guess, a little hung up on the herbal medicines. Just getting more information about that. I study kidney disease in the lab, and ursolithic acid is one toxin that we use in the lab to model the AKI to CKD transition. So that's kind of been on my mind since the beginning, just kind of anchoring on that. But I think with what I would definitely want is just a biopsy to know what's going on. I think that's the way we'd get a definitive answer. Because at this point, I'm still thinking, I guess, still C3 glomerulopathy and membranous, even though PLA2R was negative. That's also, there's been a lot more information recently about different antigens that would be associated with different diseases. So like autoimmune diseases, you have plexistosin 1 and 2 that's associated with that. If there is a malignancy going on, there's THS70A or NEL1 associated antigens. So those are all just some of my thoughts.
Absolutely wonderful. Is it great to have phone a friend? Abby comes with some great thoughts there. Abby, I see you joined quite a bit. Where are you in your training? You said you're in the lab right now or studying.
Yeah, I'm an MD PhD student. So I'm currently in the PhD phase. So I'm in a nephrology lab.
Awesome.
So I want to be a nephrologist eventually,
Awesome.
but I'll be transitioning back to clinical work soon. So that's why I needed to join and get back to the clinical side of things.
Awesome. Yeah, I see you on here quite a bit. So thank you for sharing your thoughts. Absolutely wonderful. So this APO1 nephropathy, actually, Kirtan taught us about this. He presented a case, if you remember. I don't know if Julia, you were in on this. And it's got a particular, I guess, this role to play in evolution as these high-risk alleles were evolved to protect against Trypanosonium brucei, our African sleeping sickness. So this is a genetic test that I guess, has become more known about, and I don't think there's any treatment for it at this juncture. But it does have a prognostic value, like you do tend to develop CKD progression in these patients. So, and the blood pressure is usually very high as well in this case as well. And I think that case that Kirtan had talked about, the blood pressure was way out of control. It was something I definitely learned about. Okay, back to Carlene, this biopsy now. Let's see what Carlene has in store for us. Back to you.
Yes, so the patient underwent the left kidney needle biopsy, and pathology revealed focal proliferative glomerulonephritis with organized deposits suspicious for type 1 cryoglobulinemic glomerulonephritis, which is a mouthful, with moderate interstitial fibrosis and mild arteriolosclerosis. And I do have a picture of what it looks like. If you just give me a second so I could share my screen. Okay.
Thank you so much for even bringing the pictures. That's perfect.
So this is what it would look like. So as you see, it's highlighted here that this immunofluorescence is in the setting of a monocloning staining with kappa light chain predominance of 2+ and some IgG dominance at 2+, some trace C3 and C1 complements, but with foci of segmental IgM that's trace, and as well as a C1q that's trace as well. Should I jump into the SPEP or other?
Sure. Yeah.
Give me a second. Okay, so this is how the SPEP abnormal protein band gamma region was predominantly at 0.5, and as you see, it shows exactly how this would be. This was the most important out of this document. And then we jump into the immunofixation, which shows the IgG kappa monoclonal band that was present. I don't have the bone marrow biopsy, but it does. It is consistent with kappa restricted plasma cells, and as well as kappa lambda light chain free ratio. This is from the serum free light chain assay. So you can see that the kappa light chain is 124, which is elevated, and the lambda light chain was within normal limits, but the overall ratio is very elevated. Normally it's, as you see, 0.26 to 1.65, but it's at 9.70. I think that's what I have, and that's about it.
So the C3 did have relevance, Julia. Absolutely wonderful case, very complex, and definitely a textbook on nephrology and nephrotic syndrome. What did you learn? What was the defining point from this case that you learned, Carlene?
Yeah, so I think there was a lot to learn about this case, but really we need to consider that with nephrotic and nephritic syndromes, it is a wide, there's these wide causes for either or, but we should consider that there is other possible plasma cell dyscrasias. In this case, it would be type 1 cryoglobulinemia in the setting of just trying to work up a patient that could be presenting this young and with such extreme anasacara. And trying to, be more aware that there is other possibilities for this presentation.
Yeah, what was for me what was interesting. It's a very sneaky case here, where the SPEP UPEP definitely would have relevance, and there were no features of typical cryoglobulinemia, such as the peripheral neuropathy. We just had the kidney, but no skin manifestations, no purpura, no arthralgias, or any of those features that you tend to have. I know type 1 usually can have ischemic features. Livido reticularis is one that you can have, but no joint abnormalities. So very interesting. It's just straight to the kidney. And that was pretty much causing the edema and all of the what do you call it, the peripheral features that you were mentioning here with the peripheral periorbital edema and so on. Julia, any reflections on this case?
To be honest, so many, don't know where to start. I think I learned a lot. First of all, Colleen, the way you presented it was really, really encouraging, and you took us on a journey that is just that I feel only like very experienced case presenter can do, and you included information that we had that kind of distracted us a little bit, and I think there are many striking kind of directions this case can go to, and I feel I've learned a lot, especially like that I would have not expected this in such a young man. I think that is very striking to me. No, thank you a lot. I learned a lot. I'll reflect a lot on this case. David called it out. You need as for UPEP. I think he had the right feeling. So no, to be honest, I'm very excited for Eugene's teaching points, and of course, if you want to share anything else, Ravi.
Oh
That
no, absolutely wonderful discussion, Julia, and actually a lot of learning here. So very humbled by the case. And again, Carleen, absolutely wonderful. Please come back and present similar awesome cases. We really would like to have you back as well. All right, and over to you, Eugene, for teaching points. Thanks.
Yeah, so I'll just take us quickly because of time. So we started with a middle-aged woman who presented with bilateral lower extremity edema. The very few organs that you can think about is that could it be a pathology with a heart that's congestive heart failure? Could it be a pathology with a liver that's a cirrhotic liver, or with the lungs, maybe a cor pulmonale? Could it be with the kidneys itself, which we honed down? It could also be endocrine, as hypothyroidism or some gut disorders. Or it could even just be patient losing, patient maybe inadequate intake of protein, because those will build up the oncotic pressures. And to think about edema is just extravasation of fluid to the interstitial spaces. So where is the edema? This time was in the lower extremities. We honed down to the kidneys based on some of the examination findings where we had periorbital edema. We started thinking about the fact that periorbital edema can point out to nephrotic syndrome. Periorbital edema too can also point out to other conditions. So we mentioned superior vena cava syndrome could be as a cause of periorbital edema, which also comes with facial edema, sometimes reddening. And we also talked about trichinosis. We talked about even just mere allergies. Somebody may have a bee stung and can have periorbital edema. And then we went down to the labs. The labs gave us the classic nephrotic rage proteinuria, greater than 300 grams per deciliters, hypoalbuminemia, hyperlipidemia, and our minds started thinking about a nephrotic picture. But nephrotic syndrome is not itself the diagnosis that we wanted. We want to nail down exactly which type of nephrotic syndrome it was. And other labs were done to rule out the common causes like HIVAN, hepatitis, and we realized that they were all negative. So what then could lead us to our cause? Also, one thing that we noticed was that there was some form of nephritic picture in the UA where we had red blood cells of 50. So we began to think about what could cause kidney damage that could lead both nephrotic and nephritic picture. And also the fact that this patient had decreasing renal function, we started thinking about the fact it's not likely going to be MCD, but it's actually going to be either FSGS or membranous, or even it could, one of the pivot points was that it could even be one of the plasma cells dyskaryotes, which would just be depositing IgG or light chains to be destroying the renal tubules. So other academic stuff that we picked up as teaching points was the hyponatremia, which we thought was likely dilutional because there was patient is having decreased effective circulatory volume. So RAS will be activated, and then there will be though sodium will be high, but then there'll be more water retention, and that will just cause dilutional hyponatremia. One other test that took our mind off the possibility of an idiopathic membranous nephropathy was a PLA2R, which was negative. We also did a complement, and we realized that there was low complements, and that is what brought our minds to the plasma cell dyskaryotes, which is the monoclonal gammopathy with renal significance, and which the basic understanding of that is that there's deposition of monoclonal proteins or light chains, and that would destroy the renal tubules, and also lead to complement activation, more pop of C3, and that's how we got to low C3s. So I'll stop here, and then just the key takeaway, UA will help you pick out nephrotic syndrome. Biopsy will always help you pin the exact nature of the nephrotic syndrome, and then you can go out with your treatments. Yeah, thank you very much.
Thank you, Eugene. I love that. Pin these thoughts. So Awesome. Thank you, everybody, for coming on, sharing your thoughts today. Great case. Carlene, please come back. And I believe there's another VMR, neurology VMR at 12, so please join for that. Otherwise, have a wonderful rest of your Tuesday. Take care. Bye. Thank you, Julia, for coming. Bye.